Good morning from Mount Sinai Medical Center Cardio-Catheterization Laboratories for an endovascular live case presentation today. I'm George Dangas, and with me today moderating Dr. Karthik Guja.
Good morning, everyone.
Before we go to the cath lab, let's just go through some of the welcoming as well as logistical announcements. First of all, you can send us a note during this procedure at info@peripheralinterventions.org, and we will be able to address your question live and discuss it as needed with the operators. Second, this case will be broadcast, we'll stream the video after the end of the case. So if you miss any parts, you can come back and you can review him later on. And if you have a question, then you can also address it through the blog, and we will answer it as well. And needless to say, through the same function, you can review in our archives many other previous live case sessions that we have performed. Two logistical announcements: March 25, same time. Anywhere you are around the world, we're going to meet again here for the next endovascular peripheral intervention live case, and our conference live here at Mount Sinai in June 17 to 19, 2015, on complex cases of coronary, valve, and vascular areas. And we would like to see you and interact in person here with the entire faculty from all the disciplines. Dr. Guja, anything else from you?
Yeah, I think, good morning, everyone. I think, as Dr. Dangas said, we're looking forward for the symposium and, of course, the next live case. It will be great for anyone out there to come and interact with us in person, as like we do in live cases here. It will be great. And let's go to the room and get started with Dr. Krishnan and the team. Good morning, Dr. Krishnan.
Good morning, Karthik. Good morning, Dr. Dangas. How are you? Want to present a nice case to you guys. But before that, I'd like to introduce our team. In our room, we have Dr. Vishal Kapoor, to closest to the camera. Then Dr. Jose Wiley, who's back in the room after a couple of months of not wanting to be in the room, and Bray Lascano, and we have Elizabeth and Ricky, our nurse and tech. I'm going to ask Dr. Kapoor to present this very interesting case for you.
All right. Good morning, everyone. Can I see the slides? So it's an 81-year-old gentleman with a history of renal artery stenosis with left stent, non-ischemic cardiomyopathy, EF of 35%, chronic kidney disease, AVR, gout, hypertension, hyperlipidemia, and reflux disease. Actually presents to us with the right lower extremity critical limb ischemia. He's had this right big toe ulcer for 3 months, medically managed, wound care, podiatry, but his ulcer is not healing at this time. Medication-wise, he's on standard cardiac and peripheral medications: aspirin, Plavix, Crestor, glimepiride, and he's also been covered through antibiotics, Augmentin and metronidazole, for any previous infection. Social history: he's a non-smoker, no history of alcohol or drug abuse. Just a brief overview of the physical exam. Vital signs are essentially stable. On his physical, there's a right big toe ulcer when his right TP and PT are 1+ palpable. We're just going to go over the lower extremity angiogram with you, but essentially when you see the pictures, you'll see that he has severe bilateral infrapopliteal disease, right worse than the left, and there's a right AT CTO essentially.
Can you show the angiogram, Dr. Wali? Can you go over the angiogram with everybody?
Let's go back.
Plus. So diagnostics were done because his creatinine was high, so we can tell you that there was no inflow disease. It's all infrapopliteal, as you would expect in a guy with foot deformities as well as with severe diabetes and renal insufficiency. So as far as how we did this, we got a 7 French 45 centimeter sheath and a 6 French multi-purpose guide through that into the popliteal to avoid excessive dye use. So we did not repeat the diagnostic other than below the knee. And Dr. Wali, can you talk about what you see?
Yeah, so you see the popliteal artery has some disease right at the knee joint. You see the anterior tibialis on my left side coming out that has proximal disease, and then it occludes about 2 or 3 centimeters down. The TP trunk was okay. The posterior tibialis and peroneal, at least approximately look patent. So now we're waiting for the dye to come down. You see the perineal and the posterior tibialis artery, which is patent. However, the anterior tibialis, you barely see some flow coming down.
Very long occlusion.
And then it faintly reconstitutes distally into the dorsalis pedis. You see the posterior tibialis in the back, which is also occluded distally, and you see some collateral flow towards the area of the dorsalis pedis.
So when you go back and look at the angiogram, I mean, since the ulcer is at the level of the dorsalis pedis distribution, what we were thinking about doing is going ahead and doing a direct revascularization following the angiosome concept to really look at try to get through the occluded anterior tibial artery, long segment occlusion down into the DP. The other choices for this type of patient are a FEM dorsalis pedis bypass, which again can be done, but with his renal failure as well as his cardiac status, it would be a high-risk procedure. So we thought we'd go with an endovascular first approach here. Second options here would be, as far as endovascular is concerned, we could either do the antegrade wire escalation technique or a retrograde dorsalis pedis stick, and at this stage we prepped for both, but what we're planning on doing right now is try to go antegrade. So let me show you what we've done, myself, Dr. Wally, and Dr. Kapoor.
Can you show us a little bit more the dorsalis pedis final target? I don't, just it was shown only briefly.
Right here, right here, George. I'm showing it to you right now.
Okay.
You can see that the dorsalis pedis is.
Let's try to freeze it when you have the best sense.
Absolutely.
So, yeah, it's a little bit difficult to see.
Right there.
Great.
So you see it. Do you see it there now, George?
Yeah.
Okay. So you see it's a good target, but clearly it would be a distal fem dorsalis pedis bypass, which is a long bypass. He does have osteomyelitis. He's on antibiotics. He's on all the other things. So therefore, he does need revascularization. So at this stage, our options are we're going to try antegrade through the occluded DP first, just because of the bypass target distally. It does not give us enough of space above where the target would be, so we'd be actually sticking the dorsalis pedis at the site of the target. Right. So this is a very difficult case to handle. The second point is if you're not able to do direct revascularization through the dorsalis pedis or anterior tibial into the dorsalis pedis, you can do indirect revascularization by fixing all the other vessels. The PT and the perineal also have some stenosis, and we didn't take good pictures, but we have the diagnostics from earlier, which we'll do if we're unfortunately not successful today. The other point is, as you know, there are two types of revascularization. One is a direct angiosome guided directly to the spot, and the second is indirect by increasing flow through all the collaterals. As you can see, the posterior tibial does fill the dorsalis pedis, as do collaterals from the perineal. So at this stage, Dr. Wiley, myself, and Dr. Kapoor have discussed to go with the direct revascularization. I don't know whether we will get access in the DP because we may not want to burn a bridge to a future bypass in this particular guy. But that all is on board here, and we're going to talk about different techniques in trying to get through this. Dr. Bhaskar has put together a nice little talk about the current data available on CLI with some of the new SKY guidelines and other things. So as we talk, maybe you guys can start discussing that, and myself, Dr. Wiley, and Dr. Kapoor will start to work. Let me just tell you what we're doing right now. But what we did was we went ahead. I want to show the audience at home. What you want to do is take a fielder wire and enter into the dorsalis pedis as far as you possibly can, which is around 15. Then what we did was we went with a fine cross over the fielder, and then we injected selectively into the dorsalis pedis to see where you are. So you can see you have a little bit of a stump there, and the problem here is you have multiple collaterals. So the issue is which way is this going to go? So right now we've switched to Confianza Pro, and we also have a PT Graphics wire available. And we're going to try the wire technique first. Generally speaking, we will escalate the wire technique. We'll start with PT Graphics and then go to the Confianza Pro. But in this type of calcific lesion, it may be worthwhile just to go with the big guns immediately. So that's exactly what we're doing as we speak. So Bhaskar, we can start the presentation, and Dr. Dangas and Dr. Guja, we're open for your thoughts as well.
Dr. Krishnan, I'm assuming, I mean, you said indirect revascularization. So just for the audience sake, like you want the, for the toe also to heal. I know it's a borderline angiosome, especially the toes, the tip of the toes. It could be the PT or the AT coming anywhere. So do you want the plantar arch to be completely filled by the PT to do the indirect revascularization, or would you be okay with the peroneal giving the dorsalis pedis collaterals?
Well, you know, I think that's exactly what we talked about, was the concept of revascularization. You know, I think increasing any sort of flow into this, go a little more, Oreo, please, into this is going to help. This gentleman as much as he can, and mag up, guys. But I think that you know, the ideal would be to open up into the dorsalis pedis, which is what we're hopeful for doing. I mean, you could say, why not try a crosser device or all these other devices? At this stage, Dr. Wiley and I, you know, we've done quite a few of these, and actually we really felt that the wire technique really works quite good here. So this is very complicated because of the challenging nature of the occlusion. You obviously have multiple, what is it called, collaterals at the level of the stump. So the wire will tend to get into one of the collaterals.
So this is a PT graphics?
This is a PT graphics.
Very well. Okay, let's go to the to Bhaskar, who's going to give us the slide set, and we'll be watching this in the small screen.
Got it.
Hi, good morning, everybody. I'm going to apologize in advance because my voice might sound quite raspy and it might change in tones. I'm recovering from a pharyngitis. So what I'm going to start with is some of the new set of guidelines which were a rather consensus statement which was published by Circ Interventions last year, and they have a whole set for femoropopliteal and the iliacs. So here we're going to go over the infrapopliteal. What is interesting is they've classified it as appropriate, maybe, and rarely appropriate. So even for moderate to severe claudication, if you have a 2 to 3 vessel runoff infrapopliteally, and if you have a target lesion, you can still consider revascularizing. Rest of it is self-explanatory. If you have critical limb ischemia, you do have to perform an infrapopliteal intervention after fixing the inflow. And this is considered maybe appropriate, again, moderate to severe claudication involving 2 to 3 vessel infrapopliteal disease. You can consider intervention. And again, critical limb ischemia. So rarely appropriate is, you know, when you have major tissue loss with 1 vessel IP disease, because you know that you need to revascularize much more to bring about tissue healing. These are the ESC 2012 guidelines, where they recommend, especially in critical limb ischemia, that if you consider infrapopliteal revascularization, endovascular should probably be the first strategy. And then balloon angioplasty should be the first mode of treatment used, and stenting should be used only if the PTA fails. Now these are the TAS 2 guidelines, where they strongly recommend revascularization for patients with critical limb ischemia. And if you skim down to recommendation 35, here they say in a situation where endovascular revascularization or open repair bypass of a specific lesion causing symptoms of PAD give equivalent short-term and long-term symptomatic improvement, endovascular techniques should be considered first. So this is the update from the ACCHA focused guidelines which came out. Here essentially they say if somebody's life expectancy is going to be 2 years or less, and in whom you can't obtain an autologous vein graft, then endovascular strategy should be considered first. And in patients who are expected to live greater than 2 years, and it's possible to have autologous, autogenous vein graft, then bypass is considered a excellent modality. So I'm not going to go over the basal trial, but some of the conclusions and the recommendations from the trial were listed as follows. Essentially, they compared the angioplasty versus surgery in patients with severe limb ischemia. Now, there's been some criticisms that not truly all of them are critical limb ischemia. Essentially, when you look at the study, it says that there were similar outcomes with regards to amputation-free survival and all-cause mortality and quality of life. Obviously, surgery was more expensive during the short term, and they concluded that patients who, again, lived less than 1 to 2 years, angioplasty was preferred, and who lived greater than 2 years, they were considered appropriate for surgery only if they had a good vein graft. So I think it was based on these that our 2011 focused update guidelines are. So this is some of the angiosome concept which Dr. Krishnan and Dr. Guja were going over with regards to direct and indirect vascularization. And there's been a few studies which shown that better ulcer healing, especially if you targeted the specific angiosomes. So essentially you see on the top figure, you have the anterior surface of the foot. You have the dorsalis pedis enclosing most of it along with the anterior tibial. The peroneal artery, which is essentially giving out the calcaneal branches supplying the lateral portion of the malleolus. And then here I must say that the medial malleolus usually is supplied by the posterior tibial artery, and then the rest of it is the dorsalis pedis. Now when you look at the undersurface, you have the medial plantar artery, which is one of the terminal branches of posterior tibial artery, which supplies the instep of the foot. And then you have the lateral plantar artery, which supplies actually most of the plantar surface of the foot, which is again a terminal branch of the posterior tibial artery, and then the calcaneal branch. And the anterior tibial artery supplies the anterior surface as mentioned earlier on. So when you perform a CLI procedure, some of the goals of therapy would be to dilate all inflow vessels. And in our patient, we don't have any inflow disease, so we're going for the infrapopliteal. To achieve a residual stenosis less than 30%, ideally it's great to achieve a straight line pulsatile outflow, and to at least have one tibial vessel to the pedal arch being completely patent. And again, revascularization, proportional extent of tissue damage, and targeted to angiosomes of concern. I think this is of key importance. So with this, I'm going to talk about one of the most recently published randomized trials with regards to the use of new novel technologies for infrapopliteal disease, especially the drug-eluting balloons, given that it was approved for femoropopliteal disease in October last year. So this is a European study, which is the first large multi-center randomized controlled study of the impact amphipherion drug-eluting balloon versus standard balloon angioplasty. So the patient population in this study were all critical limb ischemia. So critical limb ischemia essentially is defined as any patient with rest pain or having a ulcer, gangrene, or any kind of tissue loss lasting for at least more than 2 weeks. And usually the ankle pressures are less than 50 and toe pressures are less than 30 millimeters of mercury. So what they did was, in this study, they compared the drug-eluting balloon versus PTA in a 2:1 randomization fashion. The endpoints, they looked at two essential endpoints. Firstly, there are two co-primary endpoints, which they measured all the way through 12 months, was one clinically driven target lesion revascularization, and then they looked at late lumen loss in a subset of patients who had a 12-month angiographic follow-up. And then the primary safety endpoint was a composite of all-cause death, major amputation, clinically driven TLR all the way through 6 months. So they enrolled these patients between 2009 to 2012 across 13 European sites. They started off with close to 358 patients and finally ended up following 165 and 91 as randomized in the 2:1 fashion mentioned earlier. And this was an industry-sponsored trial. So when you look at the baseline characteristics, this is all the clinical. You notice that most of them are well matched, and most of the patients, most of the CLI patients were in the Rutherford class 5. And there was just one patient with severe claudication in the PTA arm. And if you notice that the patients in the DEB arm had a higher rate of previous target limb revascularization. I think it's important to note this difference because when you interpret the results later on, these do play a certain role. These were some of the wound characteristics. So the patients who were in the standard PTA arm had deeper ulcers, which was significant. And these were some of the angiographic and procedural details with significant differences. The PTA had a longer lesion length. Obviously, the DEB arm had the predilitation, longer inflation time, and they obviously used lesser inflation pressure. Procedural complications were little higher in the DEB arm, and post-procedural dissections was higher in the standard PTA arm. So when they looked at the 12-month efficacy endpoints, which, as you remember, is the clinically driven TLR and the late lumen loss, and when you look at other factors like binary restenosis, occlusion rate, and etc., there was no significant difference between the two arms. And then when you look at freedom from major amputation, you can see that there wasn't a significant difference. They didn't achieve a p-value of 0.05, but they were trending close to it. And you can see the red line, which is the DEB arm, was lying a little lower than the standard PTA arm. And now, when you look at these primary and secondary endpoints, you can see that the 6-month primary safety endpoint was significantly different, meaning that the DEB arm did not meet the non-inferiority analysis when compared to the PTA, meaning it was shown that there was a slightly trend towards increased major amputation as well as death and amputations taken together. And finally, when you look at the subgroup analysis, what is interesting here is if you look at these patients with Rutherford class 4, which is essentially rest pain, the DEB arms seem to do slightly better. But most of the patient population in this study was patients with Rutherford 5, which was, minor tissue loss. And you notice in this, all through the different parameters, that the patients with the DEB arm did slightly worse when compared to the standard PTA. And in this unity analysis, with regards to the efficacy endpoints, the line crosses the unity. But with regards to major amputation, there is a trend which kind of favors standard balloon angioplasty. And actually, after this trial, the use of this balloon for infrapopliteal disease has been recalled. So in the subgroup and multivariate analysis, as you remember, there were a couple of differences you saw in the baseline characteristics. So Rutherford class indicated no differences in the 6-month primary safety endpoint and the 12-month major amputation or mortality. Post-hoc analysis revealed no effect of direct versus indirect revascularization or the patency or the status of the pedal loops. And finally, when you performed a multivariate analysis, it revealed that patients being confined to bed had a hazard ratio of 3.9, which was interestingly the only significant factor identified as affecting major amputations all through to 1 year. So some of the points which I think were key in this study was it's important to acknowledge the PTA arm had longer lesions and deeper ulcers. The DEB arm had a higher previous rate of target limb revascularization. The PTA arm had extraordinarily better results when compared to historical studies. They had really good results, almost with excellent patency rates, which almost makes you wonder, whether the patients they were randomized into the PTA arm, was there a significant bias. Finally, the cohort size was insufficient to represent the entire spectrum of CLI spectrum because 85% were from Rutherford 5. And finally, the study was not powered to really demonstrate differences in major amputations. So all we can say at the most is a trend. And finally, if you notice in this study, which was actually triggered after 2 studies, one was a retrospective analysis, and the other one was a randomized study in a single center, where both of them showed phenomenal results with the DEB arm. And that is the studies which kind of triggered to this current study. But the previous studies had an excellent wound surveillance program. These patients were taken care of by wound care specialists. They had weekly visits. So therefore, they probably could have had a better result. But in this study, there was no standardized wound surveillance, which was left to individual. And also the amputation program was individualized too. There wasn't a set protocol. And finally, there has been some concerns about the balloon material and the coating process, which raises concern whether there is significant loss of the drug even before it can get to the target site. So the reason I want to end with this slide is because it's important to acknowledge that critical limb ischemia is not your plain old lack of blood supply, and therefore improving that cures the problem. I think it's probably an inflammatory ischemic process as well as an infectious component, as illustrated by this study with the multiple pathophysiological processes. So I think what I've learned and what I think is key is it is multifaceted. Agreed, ischemia is the key factor which needs to be fixed, but I think you should have a multidisciplinary approach to the management of CLI. I think with that I'll end my presentation.
Well,
Nice
what I
job,
find
Oscar.
striking in this presentation,
Well,
and
guys,
perhaps
as you
if we could
see
discuss that for
here,
a moment, was that they had, forgetting about the results of the drug-eluting balloon, I find striking that that there was no relation between the direct line versus the indirect revascularization with the outcome. I think that challenges our, I would say, intuitive in some ways thought, and it's concerning. Number one, is it dominated by restenotic phenomena because the lesions are so long? So although we achieve direct line, maybe this kind of fades away soon. Or perhaps the situation is so multifactorial that the mode of revascularization makes no difference. Or perhaps that the indirect revascularization, it may not be as bad as we would think. And perhaps in cases with aggressive collaterals, and I think we also have seen patients who have tremendous collaterals and others who don't have. And I wonder if these people differ from each other. If you see patients with so many great collaterals, these people might be particularly suitable for the indirect revascularization, perhaps. Karthik, what do you think about that finding? Was surprising?
No, I think, Dr. Dangus, the finding was actually probably expected for this study. I think they were expecting this kind of a finding. First of all, it's a fantastic presentation, Bhaskar. I mean, it's a lot of information that's absolutely wonderful. But I guess nobody is looking into atherectomy and basically and balloon, which was done previously. Laser trial has showed before that there's been some success with atherectomy. They're comparing balloon versus balloon. It's not surprising that this result is expected because in coronaries they did some heparin coated balloon studies and it didn't show any significant benefit. I know this is paclitaxel, but these lesions are long, as Dr. Dangus was saying. I completely agree with you, Dr. Dangus. Couldn't agree more.
Look what's happening in this case, for example. It's a long lesion.
Yeah.
It's pretty typical.
I think, PK, you're having a blind end. I think there are a lot of collaterals. That's where your wire is going.
Well, this is a great discussion that you guys are having because we're kind of talking about the same thing here. We're a little concerned about getting pedal access because we don't want to burn a bridge to a future bypass because we don't believe that he has a good, what is it called, supra ankle dorsalis pedis or posterior tibial, or anterior tibial
He definitely doesn't. He definitely doesn't.
He definitely doesn't.
That's the point.
So the question now is, Dr. Wild and I are talking about, is that we keep getting into this collateral here and this collateral here, and you saw that we had little micro perfs and all that, which is no big deal. But the point is whether now we should go try through the posterior tibial to revascularize the arch through the posterior tibial, which may be a little easier, which is what I'm going to do now. So I'm going to pull this back. What's the matter? What's the matter, Jose? You okay? Oh, you're sleeping. Okay. Okay. So now we're going to go into the posterior tibial.
I think, Dr. Krishnan, I think that's a great idea. I think we can revascularize the PT, give him a lot of plantar arch flow. We can always see how the ulcer heals, and if necessary, if it doesn't heal, we can always bring him back and stick the PT. Dorsalis pedis, and get retrograde access and do it.
Well, I think it's sort of like what Dr. Purushottam was saying about that. Can you go a little bit lateral so I can see my wire? About doing it in a combined hybrid manner. The other way, please. The other lateral. If we need to do a bypass, you definitely don't want to give your surgical colleagues a situation where they don't have a good target that you've mucked up because you got access. To me, the way I look at it is that, I think there are multiple different modalities which we can use to get through this, and I just want to make sure that I'm doing the one that's going to that's not going to burn bridges for the patient.
Yeah, that's very important. Let's try to see a selective posterior tibial angiography to
That's
understand
exactly what
what's
I'm doing,
happening
George.
with
I'm
this
getting
vessel.
all the way down.
Yeah.
As you can see here with my...
We had a picture that actually shows
Yeah.
that the arch was a
Yeah, let's
patent,
review
but
it a
there
little
wasn't
bit because
Right.
you know the audience is gonna take a look at our current target.
Yeah.
Dr. Wiley, I think you guys took a picture, DSA shot
We
of
did.
the
There
arch,
was-
and then
there
it
was a
shows that
picture-
the PT is CTO, right, at the
This
level of
shows
the
CTO at the
Back up.
level of the ankle, but then
That's
you see
right.
reconstitutes later on.
Right.
And it actually reforms the arch.
That's right.
You'll see it here.
You want to open the
Let's try this. Yeah. Let's just try to take one shot here.
Let me open
Just
the
2
shutter
cc's.
so you see the pedal arch.
See, there's the PT right there. And you see that?
Now,
there's
this
your
is
arch.
also very challenging because
Very
of the-
challenging, no
of
question.
The CTO as well as
The
tortuosity.
Well, you know, I mean, we're going to have to try with a fielder wire here and see how it goes. Give me a fielder wire, guys.
Let's,
Dr. Krishna, just for the audience,
Robert?
if you do indirect revascularization, do you keep a track of the TCPO2 as an outpatient and see how the patients are doing and then bring them back, or you wait for the
Robert?
whole ulcer response?
You know, I got to tell you, TCPO2 is one of those tests that's very hard to perform. As you know, you need a lot of different, things. You need a lab that's well equipped to do it. You need to have a, what is it called? The skin temperature has to be regulated. There's so many things that we have to have TCPO2. So therefore, what we do is we follow the wound in our wound care clinic here and see how the healing process is going. We don't routinely perform TCPO2 at Sinai, that I know for sure. Nor do our wound care specialists routinely send the patient for hyperbarics either. So therefore, it's really clinical wound care, watching how the wound is closing, and the use of debridement, and clinical experience. That's exactly what's happening. So I think if you have TCPO2 or if you have laser skin O2, those are parameters that are reproducible and definitely very, very powerful in terms of getting the answer as to what your revascularization strategy is.
what's your end-hole catheter you have as backup there? Fine cross?
That is a fine cross, George.
Fine cross. It doesn't even advance?
Well, no, the problem is, as you know, George, we're trying to
Very
save
good.
dye, so we are in a position here where we have a
And this is what wire you have, fielder?
fielder, just trying to see if there's a channel.
Sounds like you got halfway down, but there is a rock there.
There is a rock there. So let me have a confianza, guys, here. The problem is now we have, since we're using Dr. Wiley's technique of 2 catheters, we're probably going to run out of space here. But we'll adjust somehow, don't worry. Let's just see whether we can cross it.
Do you think the channel is a little more medial?
Well,
Because of the tortuosity?
I think the patient is moved,
Okay.
but I can give more dye. Can you mag up a lower, guys?
We'll probably give like a cc of dye and see. Because the tortuosity, it's very easy to dissect the vessel, as you know.
Absolutely, mag up, guys. Off roadmap. I think here the important one, not to mag up, please, off roadmap. The important one not to dissect is that superior collateral that's filling the DP. Show me above.
Right at the tortuosity begins, right where the tortuosity begins.
Here we go. All right, ready? Roadmap. Okay, you see that superior collateral?
Right.
I think that's more important than what the collateral we're in. Can I have a shaper? I have it.
question about that.
So, so our plan, obviously, there's a live case demonstration discussing different techniques. I think it's more than the technique of using and crossing this. I think what's important to discuss is when you should consider dorsalis pedis access and when you shouldn't. So let's ask Dr. Dangus and Dr. Guja just a question for you guys. In your experience, would you get DP access on this patient?
I would concur with PK to be a little conservative in this case for the reason that you want to have an option for the bypass, as well as the anatomy of the dorsalis pedis in this patient, essentially giving off some branches, maybe within maybe an inch and a half of a true vessel. I'm not so sure. I think the target would be too short. What do you think, Karthik? Because forgetting about the bypass, is that a valid observation? Maybe the length of the target of the dorsalis pedis is just too short?
I think you're right, Dr. Dangus. The target is too short, but I mean, if you really look at the bypass results, I think if you get a little bit access a little bit above the ankle, right where the CTO is, before the CTO, I think we are okay to. I don't think we will burn the bridge for the bypass. But the advantage is if you can open the PT, a good idea would be to go through the plantar arch, and from retrograde you can open the DP and go to the AT. You can do a whole plantar reconstruction. But looks like even this is very calcified, and Dr. Krishnan is having some trouble going through here.
Yeah, well, looks like he crossed some of the islands, but I mean, right now he's in the really deep CTO segment and has to reach further down, which is a lot challenging. We all want to hope it's kind of straight, but we don't know that.
The problem here is, George, because of our choice of catheters here, we're not able to get we've got the catheter here. We decided to go retrograde up and over rather than do the rather than do antegrade. So come off roadmap here, guys.
So
a little more AP.
Dr. Krishnan, I think in these kind of cases where there's calcification and we're expecting that you're going to have difficulty, probably antegrade fails off well, right? A 6 French antegrade would probably
go ahead, inject
do the trick here.
A roadmap. Yeah, I mean, I think, like I said, I think that I agree with both your points here that you don't want to burn the bridge to surgery here, because I think this is a very complex lesion. You can see I'm on the right track. I just need to keep going now. I'm going to try to advance my quick cross, but I'm really running out of room. I got to be honest with you, I'm running out a lot of room here, right? So I'm actually butted my quick cross all the way down now, and now I'm going to see whether I can take it down.
And this is a Confianza Pro 12 or the Confianza 9?
It's a Pro 12, George.
Pro 12. Okay, so we're going all the way.
Dr. Krishnan, your sheath is all the way in the SFA, like you're hubbed with the sheath?
Everything is hubbed here, Karthik. So the other option would be to now stick the posterior tibial in the foot and then try to bring it up. But obviously we're not making any progress here with this particular wire. So it's just a rock.
You think with the amount of tortuosity you have, sticking the posterior tibial will be a problem here?
Well, I think it would. I think the posterior tibial in the foot is definitely going to be a problem.
Yeah.
I think the only question here becomes is whether we should go back and well, we decided we're not going to stick the dorsalis pedis. So the question is sticking the posterior tibial in the foot. At least if you look at the medial plantar artery of the posterior tibial, it's patent. So we might be able to stick that. I'll show you here.
That's the CTO.
Huh?
The CTO is going to make it difficult because this is the level of the ankle.
Oh, it's a very tough case. It's not an easy case. Feel the medial aspect of his ankle, right?
Well, let me get the opportunity to remind everybody who's watching they can send us a question at info@peripheralinterventions.org, and to remind everybody watching today that the next webcast of live cases is going to be on the March 25th, same time for endovascular cases. This is a great picture actually, and shows all the different problems. The patient doesn't have a lot of vessels below, just have segments of vessels connected via collaterals. So no matter how you cut it, that's a big problem of the entire anatomy. That's why Bhaskar showed us in the previous studies, it didn't really matter which way you go.
George, I think I'm going to stick the AT on top. There's very little landing zone. I'm thinking about that area above that perineal collateral that comes off. I'm going to stick the dorsalis pedis above that, right at the
very proximal.
very proximal.
I completely agree, Dr. Krishnan. I was just going to say, I think this is not a good target for bypass either.
No, but below is though, Karthik.
Yeah, so we can, I think just above the ankle, if you stick it right below the CTO,
Yeah.
I think it will be a good target. You won't be burning the bridge anyway, so I think it's a good idea to stick the DP.
I mean, we're going to have to try here. We've tried two different ideas.
I completely agree.
I'm going to leave the wire there for now.
I think, given everything, I think it's probably better than the PT, so we'll have to go this way as a last resort.
We restart it.
Third option.
What's that?
No, I was just saying it's a good idea to stick the DP right where you were saying. I think that's a good spot.
That's exactly what I'm going to look at now. I'm just preparing this area here. We've already got the foot prepared. I just want to see where my finger is going and where I'm feeling here.
Dr. Wiley and Dr. Kapoor, just a question as Dr. Krishnan is looking for this. In general, in your practice, do you use ultrasound or you go by fluoroscopic guided access puncture, like the Safari technique?
I prefer ultrasound, as you know, you just have to localize the two veins in the one artery.
Right.
The posterior tibialis is usually easier. The anterior tibialis and dorsalis pedis is a lot more challenging.
Right.
So.
Right. So I guess same thing. If you're going primarily with the DP stick, then I will go ultrasound. But in this case, we obviously have an advantage of roadmap fluorosafe guided, so you can see the vessel both via ultrasound and the fluoroscopy, so you can actually stick it. Right. So your chances of getting success are much higher. But if you're primarily just DP stick, then yes, ultrasound is the best way to go.
Right. Dr. Wiley, I think you have the most experience with the ultrasound and the sticks. So just for the audience, would you explain how like you have two veins on the artery? When going in, do you compress the vein so that you get only the artery and then you take the access? Can you explain the technique?
Yeah, you could go either way. As long as you identify which are the two veins in the one artery, you could stick then the artery, or you could compress and ensure that now you visualize your artery in a cross-sectional view. You get access into the artery, then you change your view into longitudinal axis and advance your wire. That's probably the safest way.
All right.
Just as we do with veins when we do vein ablations, the same technique.
Give me a micro puncher, guys. Yeah.
So I guess you're seeing here that Dr. Krishnan is doing what we're talking about, roadmap, fluoroscopy, and then probably going to get a stick. So that should be a big...
Well, we're not well prepped for this, but we're gonna try to make it go here, which we usually get it done.
So Krishnan, you're getting right above the ankle area, right? That's
exactly.
Right. Okay.
Okay, little pinch, my friend. Okay, sorry. Very good. Okay. Thank you.
Now, Krishnan, with the outflow of this vessel is not the greatest. You think a bypass with this kind of outflow into the vessel will be a good idea?
I'm going to let Dr. Wiley handle that answer. Dr. Wiley, will I do the work here?
Sorry, your question was that the outflow is not that good in this case?
Yes. So you think, Dr. Wiley, the bypass is going to stay open with this kind of an outflow?
I mean, it's hard to tell. I think that if we cannot get in, it's his only option. That's the problem.
Should be in.
I mean, you still see a lot of collaterals. Perhaps it may be reasonable.
So all I was trying to do there is just get into the skin, George. And now I go to two different views to try to find the vessel. So you see I'm slightly off there. So what I'm going to do is going to pull back and just redirect it. And this is where the sharp eyes of Dr. Lascano will tell me if I'm in the vessel. No blood yet. See, this is such a disease segment we're trying to get into, George. It's going to be quite hard to get in. because I don't want to stick any lower than this.
No, no, we understand
No,
the point. Yeah, we have to be in that segment exactly.
I think below is much safer in terms of getting in. Nothing.
So Krishnan, looks like you're sliding right around the vessel. So
I see it, yeah.
so you want to go a little more anterior and
The problem is he has his foot deformity too, Karthik.
okay.
So because of that, we can't rotate his foot, and his ulcer is right below where I am trying to get access here. So it's very, it's not an excuse me, I banged myself in the leg there. Not a very easy area to get access. But again, a little bit of work here.
Exactly.
That's it. So I'm off. See that? See how far you're off?
Yeah.
So I'm going to pull it back.
I think this is a great point you're showing, Dr. Krishnan. Like you have to take multiple angles to know exactly where you are, because this is two-dimensional. So and your needle is going in. So taking multiple angles will guide you through the fluoroscopy guided access.
No, that's harder.
Yeah, I'll probably go with the AP view because I don't know how the...
It's probably the vein.
I'm in some vessel here. We're going to check. It looks like it might be the vein. Yeah.
Looks
To
like
me, I'm right on top of it. I'm probably next to it on the vein, right, Dr. Wally?
But you know what? Inject from above so we confirm this.
Okay.
All right.
Inject. Not too much. That's it. Yep, I'm in the vein.
Yeah.
Right?
Yeah, you're right next to it.
Right next to it.
Right
Yep.
next to it.
Let me flush it and restart here. Actually, you know what? It might not be a bad idea to leave this in there.
Yeah.
Oh, I'm out. Okay, let's flush this. Give me a radial needle, guys. Let me try with that thing.
So Dr. Wiley, we tried from antegrade, we tried a Fielder, we tried a Concanza, we tried a PT Graphics, right?
Yeah. Mm-hmm. Yes. Correct. Correct. You tried all this fancy wax. What you tried? Have any idea of another wax?
I think so. I think we already think the only other thing is go to a much stiffer wire than that, which might cause. I mean, I think we were already causing microperfs with these wires. So I think any other wire we use, it says because of the multiple collaterals. What do you think? I think antegrade antegrade I think is.
When you go to the AT, you can try the straight glide, I suppose, but I would not do that in the posterior tibial because that's very angulated.
Yeah, anything below Denny, I would not use 035 wires. I would only use 014 at the max, 018 wires.
Yeah.
Yeah, it's really a short target we're aiming at here. I went with a radial needle and trying to get a little digress.
Yes, sir.
There's enough to see.
Might be in.
Nope, I'm not able to hit it. Such a short area, man.
Looks like you're hitting some calcification there.
No, I'm moving the vessel. I can feel
Yeah,
it.
yeah.
We see the lumen, but there's probably hard plaque around the lumen that
Longer needle.
the vessel cannot, the needle may not be able to penetrate.
Yeah, I mean, I
It's
think
a
we've
very
just.
flimsy needle.
The only question here is whether we should have prepared for ultrasound, which might have been probably a little easier to get this spot. Yeah, I know, but I'm saying prepared to have everything, little injection.
But even with ultrasound, Dr. Krishnan, I think, with the foot deformity, as you're saying, I mean, this is a very tough case.
You're right there.
I see it,
You are
George.
somewhere. You're right there.
The problem is that
What I don't understand is why the needle curves so much. Is this? It has
again, George, the problem is that we may not be in the right plane. We're seeing a three-dimensional objects in 2 dimensions, and that's what makes it so difficult. And on him, because of the renal insufficiency, we can't be injecting.
Yeah, we're not going to give more dye.
Too much dye.
One or two more pictures, and I think we're going to call it a day here, just to really go over what are the things that need to be done. Nope. Well, only point is coming from above. Anything else we could try from above, guys?
I mean, you can try an astrado wire, Dr. Krishnan.
Yeah, but the problem was we were going into that collateral, Karthik.
You want to try the crosser?
So, Dr. Krishnan, the idea is, can you try any peroneal collateral and see if you can get retrograde through the peroneal collateral?
We discussed that too. Let's go scene minus here.
I think you can put the fine cross in the peroneal and inject, Dr. Krishnan, so that you can save some dye.
Well, we were here. We can't get through because of the rock. Scene minus.
Yeah, this is not a good target, but I'm not sure I saw something too impressive with the peroneal, although the vessel is huge. The vessel is very big.
Very big. So.
Well, I wonder if you go and inject through the peroneal may give you a little bit more of a selective idea. Well, why don't you do that, PK? You have the catheter.
So give me a vert tip catheter, guys.
But you have the.
Give me a 035 Trailblazer. I mean, not a Trailblazer. The Supercore. Let's see let's give one more shot here.
You know what? Well, you're working above. Let me see what's the ultrasound.
Yeah.
Give me the ultrasound.
Just get the ultrasound.
Remember, I don't want to stick low, Jose. I think we.
No, I know where.
Dr. Wiley wants to try the ultrasound, but my worry is I don't want to stick the DP below where I was, because we could have stuck that angiographically. The issue just becomes is I don't want to burn a bridge by sticking the DP anywhere else other than in that occluded segment, slightly patent segment.
No, correct. That's understood.
So I'm a little concerned yet.
That's okay. Where did he stick here?
I stuck above.
So this is our guide. This is our guide catheter, multi-purpose.
So Dr. Wiley's going to. No. I'm going to get this out. I want to get this out. So Dr. Wiley's going to try with the ultrasound. And what I'll do is I'm going to walk this out, and I'm going to go do what Dr. Dangus and you had suggested. So again, for the audience at home, I think this is the idea here. When you're dealing with challenging, this is a very challenging case. You saw that there's nothing patent in the foot. You saw there's heavy calcification. You saw that there's multiple collaterals, or for the coronary guys, what we call is bridging collaterals. So I think all these things are real challenges. So how are we going to overcome these challenges in order to do this? Is kind of what we're discussing. I mean, right now we're not succeeding in anything that we're doing other than bringing up the treatment options. A lot of cardiologists will say, hey, so what if you get through, let's just get through using the Dorsalis pedis that's healthy. But, I can tell you from a surgical perspective, you got to think about long-term patency in these patients. This guy has a deformity of his leg, okay? Since he has a deformity of his leg, can I move my table? Since he has a deformity of his leg, he is going to get other ulcers. So the point becomes, if you, show me down below, if you don't get a sustainable long-term patency, you are not going to have a complete resolution of his symptoms, or you're not going to have a chance of this not coming back. So at least with the vein, you may have better patencies than you are with a percutaneous approach, especially if you burn the bypass graft. So you can see Dr. Wiley and Dr. Kapoor looking at the ultrasound.
The ultrasound looks so many vessels next to each other. I don't know how you're going to find out which one's which.
Well, remember that the veins run parallel to this artery.
Right, there are two veins, right?
So you have two veins.
It looks like there are 5 vessels there.
No, but George, you have 2 veins in one artery, right? So you saw that I got into one of the veins. So the problem is we had such a short segment. I'm not certain whether it's really that patent. let's see, Dr. Wiley's trying with the ultrasound here before I give a injection through that.
It's very calcified. It's
See, very calcified.
It's definitely very calcified, Dr. Wiley. You can actually see the shadows, the calcified.
I think the only thing that makes me identify the artery is exactly this hard points of the ultra with the thing. How you want to get in there, I don't know. But obviously that's why the needle wasn't getting easy in there. Probably was deflecting off to the vein.
Yeah, I mean, and plus, you remember, we're really dealing with a short segment there. So since we're dealing with that short segment, it's very difficult, you know, because we're being very particular not to come into the healthier segment of the DP. I guarantee you one thing, the healthy segment of the DP is much easier to hit in this particular patient than is this little distal or proximal segment that's severely diseased.
Right.
So therefore, you know, we're I guess this is part of the role of the endovascular interventionalist is to understand that what is the role of surgery in CLI, and this particular patient who can have a surgery, who has autologous vein.
Sounds like he will get the surgery.
Right. So that's the issue. So you don't want to necessarily burn the bridge on this one. So, well, let them give a shot here.
So, Krishnan, you can see that area on the ultrasound is it's very even the soft tissue is very sclerotic. So you can see it's very difficult to get access at this part.
Yep. No, we can see it. Everything is so calcific there. That's what my first reaction was like this. That this is a maze of calcium and branches, and you can have veins, arteries, collaterals. I don't know what else you have in there, but nothing good.
Nothing good. Yep. So they're on the side wall of the artery. It's rolling on them.
Right.
You can see it right there. It's rolling nicely. I can see it right there. It's rolling on the thing. You got some flow and something.
Where is that?
Not great flow. There's flow. Okay. Well, you're gonna have to see where you are.
Where is it?
You see now?
This?
Oh,
over there.
Hey, don't push too much, guys. Let's in the flora. Once you're in, show me on the flora.
Yep, let's go flora.
Bring the flora, please.
Okay, let's give us please.
Yep, Dr. Wiley saved the day again.
Picture in picture.
Beautiful. Push it all the way up.
Do you think it's the vein or the artery?
I think it's the vein.
Well, we'll find out.
So let's give a little dot comment. Hold on, guys.
We're about to find out.
With the ease the wire went through, Dr. Wiley, I think.
It went too easy, I know, but
I know your wiring skills are amazing, but
Dr. Wiley not only has he got access, he has also crossed the occlusion.
It's out here. Yep. Yeah, I detached. Give me some dye, guys. Let me inject.
From up. Oh,
From
how
up
would I
top.
inject from up top?
Yeah, I got it down here. I'm just gonna inject. I'm in the perineal, George.
Okay.
no, it's in the.
What
it's
the
in
heck
the
is
vein.
happening with the perineal?
we can't inject from there.
The perineal is also.
No, you can't inject from the perineal, unfortunately. Let me pull. You know what? You'll be able to tell where you're going. Just push. Let's push it up here. Let's see what is going towards the other wire. I took the other wire out. Okay.
It went too easy, so I doubt it.
Yeah.
Well,
Yeah, it looks like it's in the vein, right, Dr. Krishnan? It's based on the track of the.
On the bone.
So, yeah.
I agree.
well, let's check ACT then.
Both Jose?
Want to leave an ID there? Or?
But Dr. Wiley, you can leave the wire here and
Correct, yeah.
probably- and use it as a marker.
This is definitely the vein.
Yeah,
But we
definitely
have the
vein.
best ultrasound. We have a sight
It's going
which
right
is
on the
not-
vein, and it's more medial than
Yeah.
the artery. So it's definitely.
This sounds
on the-
like the medial vein.
Also, we have a. What's the other machine where we can see better?
That's what I mean. We didn't set up for that. So we're gonna now we're gonna try again one more time, and then if not, we're gonna call it a day.
It's hard to see.
Sounds
fine.
good.
Thank you.
Okay,
Come forward,
well,
guys. Come forward.
let me remind everybody that we're going to broadcast this case.
Ready?
We're going to post it at the archive section of the same website, and you can ask
the whole
questions
thing?
at the blog as well, in addition to the questions you've already asked us, and we have addressed them during the talk today. And in the archive, you can also view any of the past cases. We'll definitely be here for the next webcast on the March 25th, Wednesday, same time, anywhere you are around the world, 8 a.m. Eastern Standard Time in the United States. And I want to remind you also for the live
you're right next
complex
to it.
coronary vascular valve cases on June 17 until June 19,
Well, you know what? I think we
2015
give up,
to come and join us here. Interestingly, we saw that even the peroneal is occluded distally with the collaterals.
Right.
So I don't know if that's going to go very far from peroneal point of view either.
So I think here, George, I think, you know, we're talking about what are the other options here. I think he's gotten about 80 cc's of dye so far. So I'm a little concerned about giving him any more.
Yeah.
So I think, you know, his creatinine is 2.1. He's got, you know, we pretty much have discussed the points that we wanted to hit. We wanted to talk about what is it called, the different approaches, what is the current indication for revascularization, role of surgery, antegrade versus retrograde versus transcollateral versus you know, indirect and direct revascularization. So right here, I mean, we pretty much have exhausted all what we know. I am not going to access that dorsalis pedis, which probably will make this case successful. But however, I know that it's not going to give a long-term patency, which may end up in resulting in this guy losing his leg, because I know because of his deformity, this is going to recur. So therefore, I'm going to, you know, if Dr. Wiley's going to give it up another few more attempts here, and what we're going to do is we're probably going to sign off, and what we'll do is if we're successful, we'll come back and show it to you. If not, we'll give you an update on next time on what's exactly going to happen with this gentleman.
Why don't you balloon the focal area of the PT before the occlusion?
You know what? Again, I think
We're right there anyhow.
No, I know the wire's there. You've got the focal area, but if I balloon that and I dissect it and I shut this vessel down, you know, I'm a little concerned, because you see that large collateral from the PT, or the small collateral,
That's right.
goes and supplies the distal posterior tibial, which is giving some sort of supply to his distal arch.
I think that's favorable
So I think at this stage, I mean, if I'm not going to get direct revascularization or indirect through an intact arch, I'm not going to mess around with that stenosis just because it's there. That's just my logic at this stage. I think what we're going to do is we're going to get our wonderful surgeons involved. They are already involved. They know about this, and what we're going to do is probably send him for a fem tib bypass.
Great.
I mean, yesterday we had our first New York, New Jersey endo club, and it was wonderful because we had a great collaborative conversation about a case just like this. And it was interesting because we had incredible surgeons from Columbia University and Mount Sinai, as well as NYU and North Shore University Hospital, as well as Cornell, and we talked about what are the options. And one of the things the surgeons stressed to us, which is very interesting, which we're trying to stress to our endovascular colleagues here watching on our program, is that yes, you may fail this, but you have to look at what is the perspective for the patient and why did this ulcer occur. This is a deformity of the foot, and this deformity is going to exist regardless of whether you revascularize and heal the ulcer or not. So the chances of it recurring are also very high. So you want to be able to give this guy a sustained patency of this particular vessel. So as you saw with Dr. Purushottam's comments, he talked about even with DB, the patency is obviously questionable in a randomized controlled fashion. So therefore, I think at this stage, the gold standard, you know, for this guy will probably be a fem-tib bypass, since we failed an endovascular first approach. I don't want to burn the bridge, and I'm just curious on your thoughts on my thought process.
I agree, PK. I mean, this is a great case to demonstrate where to stop. You should. I mean, it's the patient. It's important for the patient to get the best thing. So you can't give too much of dye. He's high creatinine. Yeah. So, and it's very calcified. You know, even if you cross, it's going to take a long time for you to do this. It might take some dye involved and everything. I think looking at the patient's perspective, probably long-term patency, as you said, is great. I think it's an amazing point you made.
Well, I think it's important because I think, as Dr. Dangus said so nicely, you know, to avoid that bypass target is the key, and we're trying to get into that. If you can see on the screen, that sliver of a dorsalis pedis.
Right,
I mean,
right. No, we
it's
don't
a
have.
sliver.
You don't have enough length.
Exactly. So I think we tried. We gave it a hero try, and nobody likes to fail, especially live, especially at Mount Sinai. But it happens, and it's part of the reality of what we do. But I think, like you guys both pointed out, it's the good for the patient here to stop. No more dye. I think we're done, and we're just going to let Dr. Wiley give it a shot. If he gets in the next 5 minutes, we will go ahead and try to revascularize and show it.
Some logistical question about the case. You use what type of anticoagulation?
Yeah, we're on Angiomax right now. We always, when we go below the knee, we expect a long case. We tend to use bivalirudin, so that's our anticoagulant of choice at this stage. But obviously, George, Dr. Dangas, as you know, you can use heparin, whatever you want. It's really just kind of up to you. I think, in our experience, especially here in these long cases, we tend to go with bival. And Dr. Dangas, from our coronary published data, that microperfs in the coronary heal up quite nicely without anything. So we've taken that same principle in the peripheral, in the calf muscle, in the tibial vessels. So if we do have microperfs like we did have here, we don't worry about it, and they do tend to just close up without creating compartment syndrome or anything like that.
That's good.
So that's exactly what we've been doing. So without further ado, I know Dr. Wiley's working. I'm going to keep him working because it's rare to see this.
No, it's great. If the continuation of the case, we're going to upload it in the archives of the website.
Right. And George, I really think that it's, rather than keep trying for the next hour, I think we're going to stop here, because I think that if we keep trying, we're going to hit that healthy segment, and we're going to do what we don't want to do. And I think that's important to point out. So
that's fine. We can stop here the live transmission, and if anything adds on by the efforts of Dr. Wiley, we can amend the upload in the website, in the archives. We can get questions about that. We can have questions at the blog, and we'll answer them in between now and March 25th, when is our next live case. I think I'm going to cut it short this time at exactly about an hour and 10 minutes since the start. Everybody in the audience and everybody in the cath lab, thank you for joining us, and so long from New York. Dr. Guja?
Thank you, everyone, again. I think it was a great case, and we'll definitely see you guys next month for the live case.